So this is going to be a highlight of why we all need to be talking about the same thing and the guidelines to attempt to unite us. Because my interpretation of primary pedal intervention is actually intervening in the pedal vessels and not accessing the pedal vessels to treat something else. So, you're going to get a bonus point lecture on intrapedal interventions, I guess. I do not have any relevant concepts. And just for sharing, vascular surgeons, we've been there in foot for a while as well. This is back from 1989. Most of you guys were not born as well, probably. So, amicus plato, I'm a friend of PK, but I'm more a friend of the truth. So let's start with all we're in agreement, I'm hoping. One is we're not even thinking about treating claudicators with pedal interventions. Number two, rest pain relief does not require any pedal interventions. And we're talking about, like, Rami said, Rutherford classes 5 and 6. Now, I think the first lecture actually was an infection-dominant presentation, and that was actually quite good. I'm not quite sure the timing of the intervention on the toe amputation itself, but in general, infection-dominant scenarios should be managed prior to assess for ischemia, and once you assess ischemia and ischemia is diagnosed, then you stratified based on patient risk, limb, and anatomy. And again, all this is in the global guidelines, and I think it is important to go over this type of thinking process. And eventually, whatever specialty background you have, I think we all like to think we belong to something, and somehow, somewhat, that belonging, which is a human need, transcends more than politics, but sometimes we get stuck in the politics. So I like to think as CLI interventionists as special operators. No matter what branch of the armed forces you come, you can go through grueling training and you prove yourself, and then you devote yourself to special ops. And that's kind of how we are. So it doesn't matter our background, as long as you know how to operate, and you know what to operate means, indications, when not to, when to, I think you're going to be fine. And I think that's what it should be. Nevertheless, you need to establish salvageable extremity versus non, and primary amputation, as the first speaker talked, is still a modality of choice in those patients who do not benefit from revascularization. And once you have a salvage extremity, you have actually three different things. It doesn't matter sometimes that the patient has a tiny ulcer and it's a contracted patient and has no rest pain. Those patients don't need a primary amputation. Those patients don't need a revascularization. You can palliate that, and we've proven that by writing, and they all die from non-limb related complications very soon. So conservative management for minimal ischemia is also something that we prove in the SVS, and then revascularization, which is essentially what we're talking about today. Now, traditional metrics of revascularization includes all this that we all know. And we're talking about the arterial segments throughout this course, which we all do. And the interventions that I thought we were talking about today was inframalleolar interventions. And as you can see, this is just anatomy. There is a lot of overlapping in terms of food, but circulation, but the angiosome concept, compartment concept, is actually quite important in understanding, and there is a failure mode regardless of hemodynamic patency when you're not perfusing the proper segment. So what it means prime time is the largest amount of number of people that are watching or listening at the day. That is in broadcasting. So in pedal interventions are ready for prime time in endovascular will be the largest number of operators are performing pedal interventions in most patients. And I think we can end the debate by saying that most of us are not doing that all the time. So John Porter said back then, I adapted a little bit his words, the last 3 decades of limb salvage, we discovered what we could do. It is time now to learn what we should do. And there's 3 pillars: necessity, safety, and benefit. In terms of necessity, I think I'm asking for you guys, but I'll answer for you as well. Would you perform a pedal intervention in the setting of autoiliac occlusive disease? And the answer is probably not. FEMPOP disease, and again, I'm talking about interventions. I'm not talking about access to complement an intervention segment. FEMPOP interventions, no. And BTK, I think that is the real question. And you have different pedal scores that actually are reflective of outcomes. And when you have a good pedal score, even if you have stenosis or occlusion in one of the things, in general, patients do better. And when you have compromised pedal scores, in general, the patients do worse, which puts you to the notion that, again, we don't know enough, and biology really rules. It's not just hemodynamics alone. And these are just different pedal scores, and you can see there different ones in terms of adding and subtracting. So one of the big things about pedal interventions is the lack of a bailout strategy. for severe dissection. I think we need to come up with something. I'm not quite sure. I'm not that bright to come up with something like that, but certainly we do need when things go, because if you go to Italy and you spend a little bit of time, you see sometimes when you do the pedal loop arches, they all get a major dissection and then it's game over. So you need to be very intelligent in selection, because, and I like, when you do this in end stage vascular disease, but I am actually trying to, we got a 40% failure rate of wound healing when we do interventions that we think technically they're just fine. 40%. It's pathetic. So we have to come up with a better system, and we need to figure it out. So pedal calcium scores, as we saw in the previous presentation as well, a big predictor of negative outcome in regardless of a successful hemodynamic intervention. So in terms of benefit for pedal interventions, there's not really a lot of data. The strongest data is a registry, and it shows that, and it's from the Japanese literature, that it shows that it improve wound healing and shorten the time, but does not improve limb salvage or amputation. We're still not touching that macro metric of limb salvage. But the devil is on the details in this particular registry. It's 51% of these patients were non-ambulatory, maybe living in a nursing home. So do we need to do that? Probably not. The other criticism to this study is 50% of the patients who are using as a control, nobody explained why they did not receive pedal interventions, because they were all CLI patients with, included in the registry. There was no a clear definition of procedural strategy. They didn't really say when isolated versus full loop, when is indicated. And the data is contradictory in terms of the prediction of the loop patency and the pedal loop patency and the actual outcomes. There are controversy information on that as well. So in summary, currently, there's no a clear group of patients where pedal interventions in adjunct to BTK derives unpredictable benefit. Just because we can do something doesn't mean we should. So unlike this, guys, pedal interventions are not ready for prime time. Thank you.